It's indeed a great pleasure this evening to be amidst you, gracious ladies and gentlemen, at this NDID annual conference. I thank the chairpersons and especially my friend Dr. Ashish Dingra for his remarks about me, and you all, ladies and gentlemen, for endorsing the same. The topic on which I'm going to focus my expertise today is how do we manage male sexual dysfunctions and diabetes. With pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Prakash Kothari, and Sashank Joshi, I beseech them to bless me always. I have no conflict of interest, and I'm going to give you some breaking news. Do you know that men live about 5 years less than women, and the most common cause of mortality in men is due to cardiovascular disease globally? And 45% of men are dissatisfied with their sex lives. Impotence is the main cause of divorces in India, as shown by the courts of India. And a beautiful study called the female study. Look at the mnemonic: female experiences of men's attitude to life events and sexuality. These are all the experiences of the female partners of men having erectile dysfunctions. So most of the women felt that they can obtain sexual gratification even without a good erections, but there has to be a deep level of non-sexual intimacy. Some question their own attractiveness. They felt they were ugly or they could not turn their husbands on. Some women felt their partners had some infidelity or some lafda. Some questioned the worth of keeping the relationship on. They wanted to go in for a divorce or have some extramarital affairs, etc. And some women felt that sex was not worth it at that age. It's all over. But everybody felt that the quality of life was affected. There was frustration, there was sense of inadequacy, self-blame, and insecurity. COVID pandemic, as we are going through, seeing a lot of increase in erectile dysfunction in men, and it's also proven now to be an endothelial disease. Endothelial dysfunction produces erectile dysfunction, leads to emotional dysfunction. But if you diagnose early, you can prevent early death, and education in this is the key. Erectile dysfunction or any sexual dysfunction affects the individual, affects the partner, and also affects the relationships. The flaccid truth is that endothelial dysfunction causes erectile dysfunction, leads to emotional dysfunction. But the bitter truth is that all these are the manifestations of aging and age-related complications, which even include diabetes. Now, what happens when we age? Antioxidative system is shut off. Endothelial nitric oxide is uncoupled. There is production of angiotensin II, inflammatory markers like TNF-alpha, and there's mechanical pressure. All these leads to production of reactive oxygen species. The decreased nitric oxide production leads to endothelial dysfunction, which leads to as manifestation as vascular smooth muscle cell growth, inflammation, remodeling, apoptosis, and altered vasomotion, leading to vascular complications. If aging is a disease, then life itself is a disease. No, it's not so. The main feature of aging process is chronic progression in the pro-inflammatory status, which we are all in today. And this is controlled by the cellular and molecular mechanisms, defense mechanisms. Immunosenescence is adaptive net result of our body's defense mechanism, which is in a dynamic process, and that is under our control. I call aging as inflammation because due to stress, oxidation, inflammation, cytokine, DNA damage, autophagy, stem cell aging, all due to activation of various signaling pathways, ultimately lead to inflammation. And friends, diabetes is an inflammatory disease. What happens in diabetes? High TNF-alpha, high glucose produces PKC activation, leads to uncoupling of endothelial nitric oxide, produces reactive oxygen species, and there is Rho A activation, which leads to increased permeability, and arginase, which reduces the L-arginine, reduces the vasorelaxation, and produces endothelial dysfunction. Our first data of patients in diabetes from 31 to 72 years, all men suffered from erectile dysfunction, premature ejaculation, or hypoactive sexual desire disorders due to hypogonadism. And females suffered from low desire, and depression was the most common thing which we saw in. Now, what is erectile dysfunction? It's inability to attain or maintain an erection for good enough sake, but it has to be there for almost every time for a period of 6 months and has to be a considerable amount of significant distress. We know erectile dysfunction is nothing else but endothelial dysfunction. So there is definitely a link between erectile dysfunction and endothelial dysfunction in diabetics, which has been proven beyond doubt. Erectile dysfunction can be psychogenic, vasculogenic, neurogenic, hormonogenic, drug-induced, and even genetic, because they have now identified a single locus on chromosome 6 on a helic loop, which is significantly associated with erectile dysfunctions. Endothelial nitric oxide is now proven to be an anti-atherosclerotic molecule and anti-thrombotic molecule. And if a patient has erectile dysfunction, he already has a subclinical cardiovascular disease. It's been proven. Diabetes is prevalent in India and also in China. We are losing to China. We are both are the diabetes capital of the world. And erectile dysfunction is the earliest complication of diabetes. So I call Chindia are the erectile dysfunction capital of the world. Both type 1 and type 2 diabetics are prone or have increased risk of erectile dysfunction. MASH main aging study proved that diabetics had 3 times more presence of erectile dysfunction compared. The molecular basis of diabetes associated with erectile dysfunction is there is a turning off of Rho kinase in the calcium channeling pathway. Now, what this does is it produces vasoconstriction in the microvasculature of the penis, leading to flaccidness. The another molecular basis is there is a decrease in the anti-apoptosis gene BCL2, which is responsible for the relaxation of the smooth muscle of the cavernous tissue or homeostasis. So these two mechanisms are very well proven beyond doubt. How do we manage erectile dysfunctions? Rule out psychogenic by if it is sudden onset, if he's getting morning erections, it's psychogenic. He does not need any treatment. If we assess by 2 questionnaires which are validated, IIEF and SHIM, we also advise them on smoking, diet, exercise, blood pressure to be controlled, lipids to be controlled, HbA1c to be less than 7, eye, feet, and oral hygiene to be examined every time when they come to you. We put them on guardian drugs like aspirin, ACE inhibitors, and we also do cremasteric reflex and bulbocavernous reflex to rule out neurogenic causes of it. We do the hormone study, we do estradiol, vitamin D, uric acid, phosphorus, sonography of the scrotum, Doppler studies, PSA, free and total. If we have to give them testosterone, digital rectal examination has to be done, and REGI scan. Oral hygiene is very important because salivary tumor necrosis factor alpha, which we can detect by just taking a swab, tells us the severity of erectile dysfunction. A simple CBC, and if you do platelet lymphocyte ratio, if the ratio is more than 105, he's got mild erectile dysfunction. If it is 116, he's got moderate. If 136 and more, he's got severe erectile dysfunction. Advanced glycated end products can be measured by skin autofluorescence. By keeping a hand on this gadget can tell you the severity of erectile dysfunction in diabetes patients. How do we treat diabetes? We have 3 modes of therapies. One is first line is oral drugs, counseling, and lifestyle measures. Second is injection of papaverine, vacuum therapy, intraurethral prostaglandins, counseling, and lifestyle measures. If both these modes fail, we send our patients to urologists who do penile implants or anastomotic surgery. But counseling and lifestyle measures to be followed are the mainstay of treatment for erectile dysfunction. We have 4 PDE5 inhibitors: sildenafil, vardenafil, tadalafil, sildenafil, and now there's a new kid in the block, avanafil. They all have different timings of action, onset of action, and duration of action, and some side effects they have. Side effects include flushing of the face, headache, dizziness, visual disturbance. The contraindications, we must remember it, nitrates. Patients who are on nitrates should not be given PDE5 inhibitors. The best for diabetics is today low dose 5 or 10 mg of tadalafil over a period of 12 weeks, irrespective of whatever be is hypertension, irrespective of whatever be is HbA1c or prostatic hypertrophy or even dyslipidemia. It has shown beautiful results. My friend Dr. Jyoti Dev has put these patients on insulin pump and has found improved sexual functions in almost 83% of the patients. Metformin is now proven beyond doubt to be improving the endothelial health. SGLT2 inhibitors, because of its class effect, weight loss, control of hyperglycemia, hypertension, dyslipidemia, all these are the vasculogenic causes of erectile dysfunction can be taken care of by the class effect of an anti-diabetic drug. It also prevents it. It is also cardioprotective and nephroprotective, proven by lots of studies today. So metformin and SGLT2 combined together, these patients start getting physiological erections and they don't need PD5 inhibitors. So this is the novel way where you can treat male sexual dysfunction. Buried penis syndrome, very commonly we see, just can be treated with 1 gram of metformin, sesame seed oil, local application, and L-arginine gel. In 12 weeks, we found novel treatments include low intensity extracorporeal shockwave therapy and platelet rich plasma. But these have been shown to be very good in mild to moderate, where even pharmacotherapy works. We send our patients to these therapies because they don't want to take drugs. They are afraid of side effects. Molecular newer targets include lots of new things which will be in the pipeline, but amongst all, the stem cell therapy, gene cell therapy has shown a little promise. Phytonutraceuticals in the form of L-arginine, they modulate the glucose and lipid metabolism in obese patients and diabetics. Hypoglycemia, postprandial hypoglycemia has been brought down by fenugreek in saponized form. Fenugreek also increases the free testosterone in our body. So what is new? New is a new drug called Avanafil, which has hit the market in India. 100 mg, 200 mg is the dose. 15 minutes is the onset of action. Less side effect because PD6, PD11 inhibition is very less and can be given to patients who are on nitrates, but they should skip the nitrates on that day because this washes out from the body in 5 hours and the onset of action is 15 minutes. So it can be easily given to patients who are on nitrates, but under observation. This has been tried even in diabetic patients and has been shown to have better sexual encounter profile. One, second time, third time also they were able to do it. And it was very safe without any side effects. Newer molecules which will soon hit the market are SLX2101, Mirodenafil and Lodenafil. Points to ponder. Should we consider erectile dysfunction to be a disease or a symptom? If it is a symptom, give them a pharmacology. If you consider it to be a disease, regenerative therapy or phytonutraceuticals are. So current treatments do not give cure, or 40 to 50% of patients are not responding to the current therapies which are available. So what is the unmet need is there is not effectiveness and cure. So what do? We have stem cells, the role of regenerative medicines, which is there. So stem cells have been tried. The umbilical cord stem cells were put in the intracavernous tissue in 7 hardcore diabetics who had failed erectile dysfunction medical line of therapy. And 6 out of 7 patients regained morning erections in just 3 months. So this was a cure, a fantastic improvement, even the insulin resistance. So male sexual dysfunction in diabetics also can get hypogonadism, have ejaculatory disorders, and balanoprostatitis. So retrograde ejaculation because of the autonomic nervous system inactivity, you find the semen entering into the bladder. But usually it is due to any surgeries like prostate surgery, etc. At this age, all men and women do not orgasms or become orgasmic simultaneously, and they need extended foreplay and afterplay also. What is premature ejaculation? It's nothing but there's a short plateau. There is arousal, there is ejaculation, but it's very short and very rapid. All men suffer from premature ejaculation in some time or the life. DSM-5 says that the ejaculation, the entry of the penis in the vagina and ejaculation, the duration has to be less than 60 seconds. Then only you can call this patient to be a premature ejaculator. And it should be there into 75 to 100% of the times and over a period of 6 months and with significantly clinical distress. It's a psycho-behavioral problem. All negative emotions, being self-conscious becomes a habit and it's conditioned progress. And there are no diagnostic tools available for premature ejaculation. There's no signs or findings or physical examinations. no radiological, pathological, hormonal, hematological, anything to grade or monitor. The neurotransmitters involved are serotonin, dopamine, GABA, and noradrenaline. And that is why selective serotonin reuptake inhibitors work very well, as they produce a lot of serotonin. The pharmacotherapy is given for lifelong premature ejaculations are like SSRIs, tramadol has been tried, and PD5 inhibitors. Psychotherapy is also given in acquired premature ejaculations or naturally variable or premature life. And there has to be always a combination of medical and psychological therapy for all patients who have premature ejaculation. We have so many drugs available. This is a cream of lidocaine, which has been tried for hypersensitivity glands. PD5 inhibitors have been tried. Combined psychological and pharmacotherapy really helps in our patients. Depoxetin, 30 to 60 milligram, 1 to 3 hours before the sexual activity, not to be taken more than 1 hour, not to be taken with alcohol, has been proven to be a boon. Hypogonadism is very common in diabetics. We need to rule out primary or secondary. Primary is due to testicular pathologies, and secondary is due to either pituitary or hypothalamic dysfunctions. And both can produce sexual dysfunction, which reduces the desire, which is the foundation of the sexual functions, also reduces erections, and patients get erectile dysfunctions. Let me give you the last part of my talk, ethical perspective. PD5 inhibitors, friends, today have been proven to be therapeutic in diabetics. How? Because this PK1C, which is due to PD5 inhibitors, which is formed, increases the antioxidant enzyme, improves the mitochondrial function, reduces the reactive oxygen species, and protects the heart muscle and the heart. So in heart, in diabetics heart, which is prone to get infarcted in diabetics, is protected by PD5 inhibitors. If every diabetic is given low dose of PD5 inhibitors, it is a boon for him. We have seen empagliflozin, SGLT2 inhibitors showing very good results. Metformin also helping the endothelium to refunction normally. Recent direct studies showed that diabetes can be reversed. My friend Dr. Paresh Dandona gave testosterone therapy for over a period of 23 months, and he found insulin resistance to be reduced and hypogonadism also improved in all these patients. So testosterone therapy also is a boon in type 2 diabetic patients. Dean Ornish proved long time back that just with intensive lifestyle changes, you can reverse the coronary artery disease without giving them any medications. So most of the risk factors, which are sedentary lifestyle, smoking and diet, etc., are responsible for increased risk of cardiovascular diseases. When Prabhakaran studied, he found that only thing which was lacking in Indians was a healthy diet. He showed there's good improvement in smokers, BMI improved, physical activity increased, lipids increased, blood pressure was maintained, diabetes was also brought under control. But only thing was healthy diet, which was lacking, and which was responsible for increased cardiovascular diseases and, of course, sexual dysfunctions. And even Cleveland Clinic said that if you put your patients on nutritional therapy or interventions stubbornly or strongly, religiously, they found that there was improvement in the cardiac functions. The cardiac perfusion improved just with in nutritional, and such a huge plaque was cleared without even stenting. So nutritional intervention not only halts but reverses the coronary artery disease. This is what is to be understood. So the doctor of the future will no longer treat human frame with drugs, but rather will cure and prevent diseases with nutrition. Two-time Nobel Prize winner said, nearly all diseases can be traced to a nutritional deficiencies. And it's a shame for a man to grow old without seeing the beauty and the strength of which his body is capable of. Trust me, friends, you can challenge your body. You can make it do what you want to. It can give you better results if you religiously and sincerely try to do workout. So my take-home message is, give your patient realistic expectations. Don't put them on PD5 inhibitors just like that when they come to you if they're not indicated. And friends, my last part of my talk is endothelial dysfunction. Is it reversible? Does it matter? Yes, it matters, and it is reversible with the use of statins, ACE inhibitors, antioxidants, L-arginine, estrogen therapy. Studies showed that 4 weeks of L-arginine improved the endothelial dysfunctions in patients. Coronary endothelium improved with high dose of vitamin C and all other hypercholesterolemic agents, ACE inhibition, estrogen therapy, etc. So potentially the most exciting future direction relates to improvement in the arterial endothelial function in young adults. Now, this is the mechanism which is present today. It has shown that improvement in the arterial circulation is there, endothelium is improved. So it is at this early stage that arterial wall damage is most likely to become easily reversible. So if strategies to protect the endothelium early in life can be defined and applied successfully, this may have an important public health benefits into the next millennium. So in men with ED or any sexual dysfunction, be it whatever it be, all can be halted. Hypogonadism can be managed with a short course of testosterone. Early ejaculations can be managed with counseling, exercise, drugs like depoxited tramadol, etc. Lifestyle measures not only improve the pro-inflammatory milia, insulin resistance, improve oxidative stress and endothelial dysfunction, leads to improved well-being and reduced burden of sexual dysfunctions. So what could be an ideal prescription for a diabetic with ED? Of course, counseling, lifestyle measures, OHA, insulin, whatever you want to give, but prefer metformin and SGLT2 inhibitors. Statins, put them on low dose of statins. If dyslipidemia, you put them on higher doses. Antihypertensives prefer nebivolol or indapamide if they need beta blockers or diuretics. Otherwise, ACE inhibitors or ARBs are the best. Low dose PD5 inhibitors if there are no contraindications. Low dose short course of testosterone if no contraindications, but monitor with PSA. L-arginine supplement with fenugreek, zinc must be given. Nutritional intervention, counseling, and mental health checkup is a must. So all PD5 inhibitors which are there available do not increase the desire, and 40% of these patients are not responders. So we have the basha of all testosterone, but we need to give it with caution. We have to take care of azoospermia on younger patients who take testosterone. We need to take care of older patients who can be prone to heart failure and prostate issues. So who's the Raja of all? Raja of all is L-arginine, fenugreek, and lifestyle modification in diabetic patients. Of course, control of hyperglycemia, hypertension, dyslipidemia is mandatory. We must try to love each other unconditionally, irrespective of whatever we have. We are partners of life. And feminism needs to be adored, admired, trusted, and respected. Men have erectile dysfunction. They don't take treatment. They deprive their partners of the sex or the pleasure which they deserve. This should not be. So erectile dysfunction or sexual dysfunction in diabetes is not an option for anyone. It is how gracefully we handle the process and how lucky we are as the process handles us. My last slide. It is really nice to know that if you detect erectile dysfunction as early as possible, it can be a blessing in disguise because you can reverse diabetes with lifestyle modification, put them on L-arginine and fenugreek, and you will see erectile dysfunction is a correctile dysfunction. So this is my book, Sex Has Really No Expiry Date. My last slide. Erectile dysfunction is very common in diabetics. It's a tip of an iceberg. It's the earliest marker of coronary artery disease. It's endothelial dysfunction. I call it diabetes type 5. PD5 inhibitors, short course of testosterone are ideal. L-arginine supplement with fenugreek is a boon. Heart that loves is always young. Age, weight, height are just numbers. Lifestyle measures can reverse metabolic syndrome. Erectile dysfunction, hence is a correctile dysfunction. And if so, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.